Good evening, Babu.
Good evening, sir.
Good evening, Mansari. Shall we start now? It's already 3. So good evening to all of you. As usual, I'll start with the short case first. In this 128th session on this series. Is my screen visible to you?
Yes, sir.
Okay, well. So, this is a short case. It's a 50-year-old man. He came with a history of impaired memory and confused behavior for the last 2 weeks. He was apparently normal 2 weeks prior to that. He was also noticed to have jerky movements of the body and limbs, inability to walk for the last 1 week. This is a very short history. No preceding fever or headache or anything. Impaired memory and confused behavior for 2 weeks and jerky movements of the body and limbs with inability to walk for the last 1 week. These short videos. Look at the
Rajesh, നേരെ നോക്ക്. ഈ സൈഡിൽ നോക്കിയോ.
Eyes. Okay, I will show the video once again. 2-3 videos.
നേരെ നോക്കിയേ. രാജേഷ് നേരെ നോക്ക്.
Fluttering of the eyelids.
ഈ സൈഡിൽ നോക്കിയോ.
He's got a frightened look on his face. And did you notice some jerky movement of the shoulder? Anyway, I'll show the video. The second video, the chest muscles got a shivering of chest muscles. Also some jerky movements of the left lower limb. In fact, every part of the body is jerking, but irregular jerky movements. See that one. Okay. The third bit of video.
Sister.
Is split eye and frightened appearance of patient vigilance.
Sister, go to
I play the video first.
Sister.
See the jerkiness.
Sister, Sister, go to
The last part when he's made to stand up. Look at the chest wall. And then he's unable to stand because of the jerkiness of the lower limb.
നേരെ നോക്കിക്കേ രാജേഷ്.
The whole tongue jerks now.
ഇവിടെ നോക്കിക്കേ ചിലപ്പോൾ ഓപ്ഷൻസ് കിട്ടിയതായിരിക്കും. ഇടയ്ക്കൊന്ന് വന്നത്. ഇവിടെ നോക്കിക്കേ രാജേഷേ. ഇവിടെ മുകളില് താഴെ ഇങ്ങോട്ട് നോക്കി.
In fact, rest of the examination is normal, is power normal, data normal, standard ongoing, no neck stiffness. So what is this eyelid abnormality did you observe? I'll show that video once again, the eyelid problem. Look at the eyelid contraction.
നേരെ നോക്കിയേ.
Look at
രാജേഷ്
the
നേരെ
eyelid
നോക്ക്.
movement.
ഈ സൈഡിൽ നോക്കിയോ.
What do you think about that thing?
The apraxia of eyelid opening, sir.
No, he has got some, what you observe is some fluttering of the eyelids, no? Don't you think?
Yes, sir.
Yeah. Other than inability to open, his remaining leg
നേരെ നോക്കിയേ രാജേഷ്,
is
നേരെ
able
നോക്ക്.
to open.
Yes, sir.
ഈ സൈഡിൽ നോക്കിയേ.
So what do you call that fluttering? What do you really calling that fluttering of the eyelids?
Mayuredi.
No, it's not
Myoclonus. Eyelid
it's
myoclonus.
something like, it's something like a repeated mind jerking movements occur in the eyelid, or something like a chronic movements occur in the eyelid. So these called blepharochronus. Okay. So blepharochronus refers to myoclonic rhythmic eyelid closure. Symptoms has an ill-defined anatomical localization, and etiologies are diverse. Bilateral abnormal eyelid movement can occur during either eyelid closure or opening, and some people consider as a variant of myoclonus, but may not necessarily be so, because many diseases, like including Parkinson's disease, can have the blepharochronus. So this is one of the videos which I copied from Name Channel. I will show the video. This is the eyelid. See that, just like our patient. That's a classic example of blepharochronus. So what is the diagnosis in this patient?
Autoimmune encephalitis.
Yeah, correct. So what do you call this syndrome? This can be a jerky movements of whole body, like a myoclonus, in the eyelid. Characteristically, eyeballs also.
Opsoclonus myoclonus.
Yeah, this is typical opsoclonus myoclonus. And if you look carefully, at one instance you could make out the opsoclonus, but most of the time, sometimes the opsoclonus myoclonus, the myoclonus may be confined only to the eyelid, may not necessarily be in the eyeball. So this is opsoclonus myoclonus syndrome. So what is the etiology now in this patient? Like paraneoplastic syndrome, one of the two most common causes is paraneoplastic, second is post-viral. Okay, so what do you need? Paraneoplastic antibody profile. That was them. These are antibodies which came as negative. What do you do now?
Steroid.
In fact, no, he had an inflammatory lymph node enlargement, which is biopsied, and that biopsy report showed lymphoma. So it's actually paraneoplastic syndrome secondary to lymphoma. The only thing is a very short case, it's nothing great in that case. But only the point is sometimes you need not get any antibody positivity. Still, you have to strongly consider the back of the mind paraneoplastic syndrome and look for an underlying malignancy in the mind, preferably with PCP. Actually, for us, he had a gland which could get it in the intraocular area. So that made our job simple. Okay, shall I go to the next case? Any questions in this case, or it's good?
Second, autoimmune encephalitis cause similar problems.
Exactly. This is also an autoimmune phenomena, usually related to some antibodies. It's all autoimmune phenomena. The autoimmune encephalitis can be paraneoplastic or non-paraneoplastic. This is a paraneoplastic type. Even the classical post-viral is also an autoimmune phenomenon. The treatment is steroid.
In this can we give steroids?
In this case, like we did not use steroid. We sent the patient biopsy. He said, I did not know what happened to the patient next. This is I did not know what happened following that. Steroid must have been given. I don't know. Because I saw the patient only once. Okay, shall I go to the next case? Any questions? I couldn't hear the sound very clearly. Okay. This is a story of a 70-year-old man. This case belongs to Dr. Divya. We worked with in this hospital. He was perfectly all right 2 days prior to admission. That night, that day before yesterday night, that is 2 days prior to our admission. That night, at 3 a.m., he got up from bed, complaining of neck pain, and got up from the bed and went to the central hall and was lying on the sofa. After some time, tried to get up from the sofa, but he noticed that he could not get up. He called his daughter, and she noticed that he could not move both his lower limbs. At that time, there was no upper limb complaints, and he could lift both upper limbs very well, as even as done by his doctor. On the next day morning, he noticed he could not move both his upper limbs as well. However, he could speak normally. It's a short story, relatively rapidly progressing, evolving over a period of few hours, inability to move both lower limbs followed by upper limbs. No sensory complaints. This is the patient's video. He could be completely conscious. He could move his eyeball normally. There is no nystagmus. There is no restriction of eyeball movement. There is no weakness of the iris of the leg. Lower pressure is also normal. He is on a rise tube. Certain movements are normal. And moments are all normal. See that for the good parietal movement. In fact, I asked why he was on a rise tube. The sister told me that he had some swallowing difficulty while giving fluid, was coughing. That is why rise tube was put. But parietal movements appeared normal. The second part, he has got weakness of both. Zero power, some degree of power is there. There was no next stiffness. Don't happen there when the there was no pronator catch, but the finger flexors is fasting. That is normal. Finger pressure is appeared fasting. You can see the catch, you can see it in the hands. Power is zero in both upper and lower limb. Project was normal. Upper flexors are brisk, both upper and lower limb are brisk. Finger flexion was just elicited. Knee and ankle jacks are also brisk. And there was both upgoing. The sensory system, he could appreciate pain normally in all four limbs. There was no sensory level. Is it equal all throughout?
ഒരേപോലെയാണ്.
None reflex were absent.
ഇനി വേദന
No
കൂടുന്നെങ്കിൽ
sensory level
പറയാം.
at the trunk.
എല്ലാം ഒരേപോലെ ഒരേപോലെ ഉദാഹരണം. ഇതൊക്കെ ഒരേപോലെ ആണെന്ന് പറയാം. ആണല്ലോ, ഇതൊക്കെ അറിയാമല്ലോ അച്ഛനെ. അച്ഛൻ ഇപ്പൊ ഒരു കണ്ണടിക്കുന്ന പോലെ തോന്നുന്നുണ്ടോ?
He could feel vibration normally.
ഉണ്ടോ? ഉണ്ട്. ഇപ്പൊ ഉണ്ടോ?
Even the little finger he could appreciate.
ഇപ്പൊ ഉണ്ടോ? ഇപ്പോഴുണ്ടോ? ഉണ്ട്. ഇപ്പോഴോ? ഇപ്പോഴോ?
Volume also is able to feel.
ഇപ്പോഴേ ഉണ്ട്.
But however, joint sense was grossly impaired about the brain.
അറിഞ്ഞൂടെങ്കിൽ അറിഞ്ഞൂടാ. അറിഞ്ഞൂടാ. ശരി. ഇപ്പോഴോ? അറിഞ്ഞൂടാ. അറിഞ്ഞൂടാ. ഇതോ? മടക്കിയിരിക്കുകയാണോ നൂർത്തിരിക്കുകയാണോ? അറിഞ്ഞൂടാ അല്ലേ? ഇപ്പോഴോ?
He couldn't tell where it is up or down.
നൂർത്തിരിക്കുന്നത്. ഇപ്പോഴോ?
Impaired in the feet also.
അറിഞ്ഞൂടാ. അറിയാവോ അറിയത്തില്ലേ? ഇല്ല. ആണ്. ഇപ്പോഴോ? ഇപ്പോഴോ? ഉണ്ട്.
Again made mistakes in both the lower limb.
ഇപ്പോഴേ? കഴുത്ത് അങ്ങോട്ട്.
On examination, Taylor's all normal except for the lateral rotation of the neck. Extraocular movements and parallel movements were normal. He was put on a rails tube when the Watt sister noticed mild cough and swallowing. However, parallel movements were normal. Motor systems positive both upper limbs, mainly on the finger flexors. Weakness of neck flexion, weakness of lateral rotators of the neck. Grade 0 to power of all muscles of upper and lower limb. DTR, disc DTR, both upper and lower limb, except for both finger flexors. Abdominal reflex absent on both sides and are upgoing bilaterally. Sensory system, touch pain normal all over the body. He could appreciate vibration all over the finger, on all the fingers, knee as well as over the toes. Joint position sensation was grossly impaired over the fingers and toes. So this is the story. So any clarification you can ask before we go to localization. Okay. Where is the localization in this patient?
Medial medulla, sir.
Bilaterally?
Yes, sir.
Okay. I can upper cervical cord also. Okay, so this can go with the, because cranials are all normal. There is no weakness of the tongue, no weakness of the palatal muscles. That was moving normally. It can be upper cervical myelopathy.
The bladder was involved.
Bladder, because I saw him for 6 hours later. He's already put on a catheter. He was in the ICU. He was put on a catheter.
But there was some cough during swallowing.
He had cough during swallowing. The point is that, but his palatal movement appeared. Whether it could be a selective weakness of the pharyngeal muscles, I am not very sure. But the tentina as such is clinically normal. But even neck muscle weakness can produce difficulty in swallowing. Because we need help of strap muscles to elevate the cricoid swallowing. So that itself can produce difficulty in swallowing per se. But if it is selective or a partial effect of the tentina, affecting the lower part of the device umbilicus, that cannot be removed, affecting only the pharyngeal part of it. But grossly, no cranial level, no clinically crude cranial level.
So here, it thinks that high cervical, upper cervical cord myelopathy, but power is 0 to 1, and
0 to 1.
sensory is not that affected.
But sensory is affected, posterior column is affected, pain and touch is pain.
But still, that will not explain with such an extensive
Correct.
patient.
So what do you think?
Bilateral. It cannot explain because bilateral corticospinal tract and the
Hmm.
0 to 1 power
Hmm.
and very selective involvement of German position sense of the toes as well as the fingers.
Yeah,
So
correct.
that will not be explained by just the upper cervical cord.
Okay, so what do you take to postulate?
I am thinking whether it is an element syndrome predominantly
Yeah.
with the additional cervical myelopathy which is contributing to the robust reflexes or something.
And that's a good thought because your little acute predominantly is your 0 power of upper and lower limb. Relatively precursor sense except the joint positions. That's a possibility.
But definitely the first cervical cord will be the first thing that I would like to rule out in this particular.
The pain panda and sparsity of the finger. Yes.
But
Okay.
he had pain and followed initially lower limb followed by upper limb. Maybe a lesion in the upper medulla, so in the anterior part of the medulla where the corticospinal tracts are involved. Any compression that can cause.
Okay. That's what which was also telling. It's a good possibility. But only point is that 12th nerve is pain, no?
Any compression anterior and posterior part of the upper cervical cord can cause dorsal column involvement with anteriorly corticospinal acute lesions.
Okay, but that's another possibility. Agree with that. Acute compression cervical cord can cause. There's a countercoup compression posterior and detail. Okay, these are the possibilities to keep in mind. Okay, so it could possibility could be ischemic myelopathy or acute disc prolapse. Other possibilities, so it's also what test you need now?
MRI.
Alright,
My cervical spine. Okay.
whole spine.
Okay, my cervical spine was this is cervical spine. You can see the cervical cord is normal. It's also appeared normal. This is the axial cut. This is cervical. CBJ means cervical craniovertebral junction region. This is CB junction is normal. C2, C2, C3 is normal. In C2, C3, C3 level. C4, 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 and C4, C5. C5 segment level normal. C5 level, C5, C6 is normal. C6, C6, 7 normal. C7, D1 also normal. This is the T1 axial. Okay, nothing. Okay. So what do you want now?
So diffusion also was normal.
Of the cervical cord. Cervical cord diffusion was not done.
This was done on day 1, no, sir?
Day 1 to there's roughly about 8 hours after the onset. But this happened that night before, about 3 a.m. The MRI was done next day afternoon. 8 to 10 hours later. You want MRI brain, no? Right.
Yes,
This is
sir.
MRI brain. Yeah. This is the flare sequence. Medulla, pons. This is the diffusion. This is ABC map. This is SWI. Angiogram done. Normal. The upper part you can see the pupil artery. So
Say diffusion normal, sir.
I can enter the diffusion films, I can show.
Some hypertension in the middle. Yes, the left ones.
Left is hyperdensity. Good.
Sir, medial medulla.
Right. Okay. Right. So let us analyze the picture now. There's only one speck of hyperdensity, I'm not very sure. Okay. So it is a pyramidal tract. The localization is the pyramidal tracts at the rubber C equals C3. The sternocleids are affected because we have weakness of both sternomastoids. What is evidence that the lesion is not in the cervical cord? This is the first point. In history, we thought since scale nerves are spared, likely to think more like the cervical cord, upper cervical cord. Clinically, what is the thing evidence? As you all said, and bilateral pyramidal weakness of both upper and lower limbs in posterior column sparing the spinothalamic tract. So, an acute is a posterolateral syndrome. In structural lesion affecting the posterolateral syndrome like that, it should affect the spinothalamic tract as well. It's total sparing the spinothalamic tract. So, structural lesion in the spinal cord, either in form of ischemia or acute compression, I should totally spare the spinothalamic, only affect the joint persistence of the posterior column. That's exactly all. Because the lesion has to affect both the pyramidal tract and the posterior column, it is very unlikely to involve the spinothalamic tract as well. Moreover, it does not fit into the vascular territory of the spinal cord arterial survey. Because posterior column is by the posterior spinal artery, the pyramidal tract comes under the supply of the anterior spinal artery. So then again, an acute presentation we consider the possibility of ischemia. It's unlikely to be in the cervical cord. So you have to necessarily think of a site where the pyramidal tract and posterior column come close together. And in the middle. Look here, this is a pyramidal tract, that's a middle lemniscus. So you can lesion there can produce both pyramidal and posterior column, sparing the spinothalamic. In the middle, spinothalamic tract is far away from the pyramidal tract, close to the posterior column. So you have to think of a lesion. But we don't have anything concretely, it's an abnormality in the middle. But in fact, as here the doctor has pointed out, there is some hyperdensity in the diffusion weight image. Actually, he had a lesion there, which I did not show you actually, because I wanted a discussion. This is the diffusion restriction that I did. Aspect of hyperdensity. And that was the lesion causing the aortic region and the posterior column. So you see correctly, there is an anterior spinal artery involved producing anteromedial impact to the medulla. Now look back, the same picture I have shown as you are correctly picked out. This is small hyperdensity there. It is totally missed initially by the people because it is so small. So this is the picture. But if you're looking back, even the first T2 weight image has got some hyperdensity in the T2 weight, but we're not very sure about it. So MRI was repeated on the third day. You can very clearly see the heart. Both. You can see the heart sign. So heart sign due to the bilateral middle impact. This is heart sign, which you can see there. This is the diffusion cervical cord showing its in fact extending from the medulla to the anterior part of the spinal cord because it is the anterior spinal artery. The spinal artery joined together from a single antispinal artery, and that is array supplying the both sides of the lower medulla. And comes supply of the anterior constant upper corpus. That's where probably the sternum should also go to. This is the hyperdensity anterior. The T2 sage, again you can find out that this is done after 5 days. You can see the hyperdensity extending down. then T2, exhale. See the appendix extending down to the spinal cord, the upper cervical cord. And now in the medulla here. And this one, this center appendix sit in the both pyramid. And going to central density in the sagittal, the flare side also. So this is an uncommon combination of two major syndromes affecting bilateral medial medullary region. Associated symptoms are flaccid paraplegia, swelling in the face, hypoglossal nerve, and the respiratory failure. See, hypoglossal nerve need not necessarily be involved in anterior medullary syndrome, medial medullary syndrome, because that nerve passes to the outside of the pyramidal tract. The pyramidal tract medial part is affected, you can sometimes spare the hypoglossal nerve. And this is the location where the involvement is. This is the site population where this particular patient had. So the endospinal artery are joined together, and this is the area of infarct which you have seen here. This is hypoglossal nuclei, which may get involved or which may not, depending upon the extent posteriorly and extend laterally. If the fibers are coming like this and going out like that, the lateral extension is not much. They can spread us in our patient. I think I'll skip these things because to the important clinical points. Because the leg fibers run in the ventral part of the medial meniscus, just closer to the pyramidal tract, sensory loss in the leg may be more severe than in the arm. That's also another point to keep in mind. The hemiparesis usually excludes the face, but facial palsy may occur in patients whose human fibers of the face swing down into the medulla and to cover prostrally onto the pons which the subthalamic nucleus. That means even in medial medullary syndrome, you can have a contralateral human facial palsy, even though subthalamic nucleus is situated well above the medulla. This is because the descending fibers, they loop in the anterior medulla and from the opposite side and ascend in the posterolateral medulla. That is why in lateral medullary syndrome, you can have ipsilateral human type of facial palsy. In medial medullary syndrome, you can have a contralateral human facial palsy. Sometimes ipsilateral tongue weakness occurs because of the paramedial interaction course. Okay. Then next one. Sometimes even human tongue palsy can also occur in medial medullary syndrome. Isolated bilateral tongue cramps may be the only manifestation of medial medullary infarction. Some patients can have vertical nystagmus and other mind movement disorders. So why the tongue is sprayed? In one study, only 6 out of 13 patients had hypoglossal palsy. The absence of tongue involvement may have several reasons. It may not the medial medullary lesion may not extend laterally to interrupt the hypoglossal nerve fibers or dorsally to involve the hypoglossal nucleus. Moreover, the hypoglossal nucleus is a long column of cells along the medulla, and a lesion in one small portion of which may not cause any dependency. In addition, hypoglossal nerve fibers sometimes appear to be preserved in the area of infarction. The characteristic MRI finding is the heart appearance. This is from the literature again, showing the heart appearance. Even bilateral medial medullary syndrome can occur due to unilateral vertebral artery lesion also can occur, where the artery crossed to the opposite side and supplying both pyramidal tract. So one question to you, why the vibration is spared in this patient? It's got joint present cells long. Vibration is spared.
Maybe the representation is the posterior part of the meniscus.
Different fibers, sir, not the posterior column.
No, in fact, even with both upper and lower, JP sensation is affected. It's not there selective involvement here. So why should vibration fibers are not separate from that?
More medial is
Pardon?
more medial is the joint position sense fibers.
That's not the reason. No, the vibration actually the same fibers which carry the touch sensation fibers. The point is that The vibration sense sometimes are carried through the spinothalamic tract and not to the posterior cord. That is why sometimes in usual syringomyelia, if you examine, many of them have diffuse anesthesia, including vibration. The GP is not the only posterior sensation which may be spared. In a good number, I don't know exact percentage, the vibrations the fibers carrying the vibration sense pass through the lattice fiber and not to the posterior cord. That's the reason. Sometimes it can be spared. Okay, any questions?
So the cause of bulbar weakness in these patients.
You mean the palatal weakness? There are two, there are two ways you can explain it. The pharyngeal so-called apparent difficulty in swallowing can also occur due to weakness of the neck muscles. Because swallowing requires, during the pharyngeal phase, you have to have an elevation of the hyoid bone, that is the thyroid cartilage, help the closure of the epiglottis. This is a disease carried out by the strap muscles, the thyroid and hyoglossus. So what happened means that, so that when that muscles are supplied, that muscles are supplied by the ansa lenticularis, that. When that is lost, that's affected the cervical cord, you can have dysphagia. So it's a profound neck muscle weakness itself can produce difficulty in swallowing. Other explanation is that, the 10th nucleus as well as the 12th nucleus is a quite long one. It is not confined to a small rounded area. It's the longitudinal extension is quite long. And there is a lamination in the nucleus ambiguous. The cranial part for the palate, the middle part for the pharynx, the lowest part for the larynx. So if the affection happens to involve only a lower part of the nucleus ambiguous, can spare the palatal muscle. It can only involve the pharyngeal involvement. Here I cannot assess the pharyngeal muscle weakness because we have to look for the correct scientific. What we need to look for is only palatal involvement. That is why it's appeared normal. Most probably he had involvement of the 10th nerve also. That is the only explanation I can give. Other way to explain is the weakness of the strap muscles. Any other questions before I go to the next one? Shall we go to the next case?
Yes, sir.
Yeah, tell me, Bindu. Shall I go to
Sir, the tongue, no, that patient. The tongue.
Yeah.
The tongue was not at all involved at all, sir. This patient.
This tongue was totally spared.
Okay.
It can be spared as I shown the explanation why it is spared. In a study out of 12 cases, only 7 patients had tongue muscle involvement in Madhusudanan syndrome, middle Madhusudanan syndrome.
Okay, sir.
Okay. So I'll go to another story. The story of a 52-year-old lady. She was noticed to have a decrease in the size of the left palpebral fissure for the last 3 years. For the last 4 months, she noticed that her left eye gets progressively smaller on prolonged speaking and while writing. She has to put extra effort to lift her left eyelid. That is the story she gave. No diplopia at any time. 1 month back, she had right element facial palsy, suggestive of Bell's palsy, which has almost totally improved over the next 3 weeks. I think that seems unrelated to the previous problem. In fact, she came to me for not facial weakness, but for the progressive size of the ptosis as referred by the ophthalmologist. So in summarizing, it has got decreased size of the palpebral fissure for 3 years. For the last 4 months, she noticed that her left eye gets progressively smaller and prolonged speaking and while writing. This is the video of the patient. First, I will show the ptosis and the ptosis is there, which is not helpable. I ask the patient to look down. Again, ask the patient to look up. Again, looking maximum up.
താഴോട്ട് വരട്ടെ ഇവരിൽ തന്നെ നോക്കട്ടുമ്പോൾ
The movements were all normal.
ഇനി നമ്മൾ നേരെ നോക്കാം.
Okay, that's the first. The second part. So, what did you observe in this patient? You had the eyelid. There is left-sided ptosis, which is not corrected on looking up. On looking at left lower eyelids is lower than on the right side. On looking down, sorry, looking down. Now, let's do the pupil examination. There is an isocoria, right pupil is slightly larger, form here it is smaller. And the reaction is slightly less on the left side. It is less reacting, but right is reacting. There's reacting there on the right side. Left is smaller.
കണ്ണ് മുറുക്കി അടയ്ക്കുമ്പോൾ
It's got right orbicularis weakness due to the right 7th and 8th.
തെറ്റ് ചുളിച്ച് തെറ്റ് മുകളിലോട്ട് ചുളിക്കുമ്പോൾ മതി മതി.
So you want to show the video of that pupil once again. Right pupil, larger, small left is smaller. Reacting is there, but less on the left side, much less on the left side. Good reaction on the right side.
കണ്ണ് മുറുക്കി അടയ്ക്കുമ്പോൾ
Okay. So what did you observe? The pupil is smaller compared to the right. There is significant asymmetry, maybe more than 1 millimeter. The pupil reacts to right light, but much less compared to the right. So what is the diagnosis in this patient?
Honors.
Okay, the straightforward thinking is honest. Any other possibility?
Serious spinal reflex.
Right, I did not. Serious spinal reflex it can be used for only in the third order neuron involvement. I not be useful in other type, other side solution for design honors.
Old photographs. Once this dose is present there.
Old honors.
Photographs.
Old photograph. Okay, I did not. She came here to OPD, so I examined.
One possibility is honors, second is LPS disease, and pupillary asymmetry.
Maybe unrelated.
Very
That's a good. We got to think all the possibilities. Okay, any other possibility? Even I like to volunteer.
Any fatigability, sir?
But
Pardon?
Fatigability, sir.
sir, left,
Yeah, tell me. Yes.
sir, left eyelid is lower than the right. No?
On looking down, the eyelid is lower than the right side. Okay.
So how can it be honors?
I didn't get it. I didn't get you, Bindu.
Sir, left in the left side, the lower eyelid is very much lower than the right side. No.
Yes.
So can that occur in honors? Like
Yeah, that can occur in the honors.
enophthalmos means it is inside, no? So the eyelid, lower eyelid should not come down, right?
No. Enophthalmos actually is not it's a, whether it's present or not is still questionable. Okay, because of the lower posterior eyelid, people call enophthalmos. Actually, it may not be there. Whatever it is, there is a partial ptosis there. Correct? It's not a
Okay,
full.
sir. Yes.
Sir, did the right seventh improve, sir, completely?
That improved, almost totally improved. That's unrelated Bell's palsy. I think you can forget about that seventh palsy. Okay, so let me ask. So left honors is a straightforward thinking. So points again is left honors. The one important point is that the ptosis is not correct. In honors, the ptosis is correctable on looking up. Other point is reverse ptosis, that is on the left eyelid be higher compared to the right side. But there can be some other red flags for that. I'll come to the later. So now you look at the next group. You all forgot one part of the history in this patient. Okay, now look at the patient's history. Look at their palpebral on the left side. Ask you to go on speaking.
നമ്മൾ വെറുതെ ഇരിക്കുമ്പം കണ്ണടയുന്നതായിട്ട് തോന്നുന്നില്ല. നമ്മൾ എഴുതുമ്പോൾ സമയത്തും വായിക്കുന്ന സമയത്തും ചിലപ്പോൾ അല്ലാതെ തന്നെ നോക്കുമ്പോൾ ഇങ്ങനെ ചെറുതായിട്ട് അടയുന്നതായിട്ട് ഇപ്പൊ ഈ മറ്റേ അറിയാൻ പറ്റത്തില്ലായിരുന്നു നമുക്കിങ്ങനെ ചെറുതാകുന്നെന്ന്. ഇപ്പൊ നമുക്ക് അങ്ങനെ അടയുന്നതായിട്ട് ചെറുതായിട്ട് അടയുമ്പോൾ നമുക്ക് അറിയാം. ഈ വണ്ടി ഓടിക്കും, സ്കൂട്ടി ഓടിക്കുമ്പോഴും ചിലപ്പോൾ തോന്നുന്നു അടയുന്ന. അപ്പൊ കണ്ണിങ്ങനെ വലിച്ചു തുറക്കുമ്പോ അങ്ങനെ പെട്ടെന്ന് നമുക്ക് അറിയാൻ പറ്റും. ഇപ്പൊ ശ്രദ്ധിച്ച് ഞാൻ തുടങ്ങിയപ്പോഴാണ് ഇത് ഇനി കാണിക്കണം എന്ന് വെച്ചാൽ അപ്പോഴേ ഈ ബെൽസ് പാൾസി പോലെ വന്നത്. എന്തായാലും ഇത് മാറിയിട്ട് ഡോക്ടറെ കാണിക്കാന്ന് തന്നെ വിചാരിച്ചു. അങ്ങനെ അവിടെ പോയത്. അപ്പൊ അവിടെയും പറഞ്ഞ് ഇത് കണ്ണിന്റെ പ്രശ്നമൊന്നും അല്ല, ഒരു ന്യൂറോയെ കാണാൻ പറഞ്ഞു. അങ്ങനെ മറ്റേ ഡോക്ടറെ അടുത്ത് പോയത്.
കണ്ണ് തുറക്കാൻ ശ്രമിച്ചേ, തുറക്കാൻ ശ്രമിച്ചേ, തുറക്കാൻ ശ്രമിച്ചതിന് മുകളിലോട്ട് വരെ നോക്കിക്കൊണ്ടിരുന്നേ. ഇനി തന്നെ നോക്കിക്കൊണ്ടിരിക്കണേ, ഇറങ്ങും മാറ്റല്ലേ, കണ്ണിൽ തന്നെ വിരലിൽ തന്നെ നോക്കിക്കൊണ്ടിരിക്കുക. There is no fatigability. On forward and progress. Okay, what did you observe?
Jaw winking.
Not jaw winking. That means on continued speaking, the palpebral become progressively narrower and narrower. Did you notice that thing?
Yes, sir.
Yeah, if you look at the first part, this is the beginning. It goes up. See, it becomes much smaller now. It becomes even more smaller. Did you see that? Did you see that? Yes. Sorry. I'll fast forward like that. See, it is much smaller than before. So what does it mean? Is it fatigability of the orbicularis? Could be. What is your impression? In fact, that is one of the complaints she said. While writing and eyelids.
Aberrant reanimation between the muscles?
No, it's not during contraction. Going on gradually it becomes smaller and smaller.
Sir, lower eyelid is also higher.
Exactly. That's the lower eyelid is also going up. That means it's a orbicularis oculi overaction. But if it is a fatigability of the ptosis, the lower eyelid should not go up. If you look at the left eyelid is also going up. I will become overaction. So what is this condition? My whole orbicularis oculi overacts. That's a candidate dystonia, or it may be functional bifurcaspasm. It's a bifurcaspasm, either organic or functional. These are the two possibilities. Now, continue to speak, but will become progressively smaller. In fact, she was seen by an ophthalmologist earlier, and they think they detect the pupil diameter to be slightly normal. Left side is 2 millimeters, right side is 3 millimeters, and that's a diagnosis possibility. So, what do you want now? What does you like to do? You have to find out what is causing the ptosis.
EMG.
Okay, EMG, and before that, so even though we noticed that we don't want to roll out in fact, patient came with an MRI brain. So I'll show the MRI brain. If that's normal. If you want a new RNS also nails already done from outside, came with a negative result. Now, what do you want to do? Now, let us analyze the problem one month. We got two problems at hand. What is causing ptosis and what is causing pupillary constriction on the left side? These are the two. Let us analyze the ptosis first. What are the points against harness? I already told you, ptosis is not correctable. And secondly, why should the ptosis get progressively worse and prolonged speaking? Why should the harness syndrome produce that thing? That should not happen. Could be myasthenia. So did a neostigmine test. This neostigmine test.
This is now 3 minutes after neostigmine.
It is 3 minutes, 4 minutes after neostigmine. Absolutely no improvement of the ptosis. It remains the same. So a myasthenic fatigability and prolonged bleeding is very unlikely. So it could be due to overaction of the orbicularis. If you look at the video, you can see the left lower leg is going. So it's the orbicularis overaction. So there is a clinical point by which you would suspect a overcontraction of the orbicularis as cause for the ptosis, or apparent ptosis, not a real ptosis. So what else you need to confirm the hypothesis? Mansell has already told that point. I want to confirm orbicularis overaction.
EMG.
Okay, EMG. So I did the lower eyelid rather than the upper eyelid because I want to be certain it's overaction. Just start inserting it. There is a continuous activity coming up. The moment I insert again, this overact, even just inserting its continued motor activities is showing that she has got orbicularis is overacting or contracting. Whether it is voluntary or not, we can't be certain, but it's overacting. So whether it could be bifurcaspasm or function, these are two possibilities. The next problem is what is causing here meiosis. So we are sorted out the problem of apparent ptosis, which is not the real left fibrous superioris weakness, nor Horner syndrome, because Horner syndrome is not because it's not a correct problem. Now, what is causing is meiosis. There is a next problem. Is it physiological anisocoria? Or is it a part of the, it's got a Horner syndrome itself, bifurcaspasm with Horner's, or due to some old nephrocyclitis. What test will you do? There could be Horner syndrome. Now, what test will you do to find out the Horner syndrome?
Ciliary reflex.
Ciliary reflex is not a root to diagnose Horner syndrome. And because that is positive possible absent only in the third order neuron.
Dilation in dark room.
Yeah, that's the thing. For a dilatation lag. Ideally, you should have infrared light to find out this thing, but that's not available because you only play on bedside. So look for the dilatation lag. So if it is a Horner syndrome, if you look into that dim light, it should be still remain constricted. Right? The normal pupil dilate, this pupil remain constricted. In my case, only lag will be there. In severe cases, the pupil will not dilate on darkness. So what I did, I put the stuff to the dark room and showed the light below so that it falls equally on both sides. Then
light it, light it.
Then you find the pupil asymmetry. Right one, it is a normal slowly dilating. You see that? It's slowly dilating on the right side. See the asymmetry is gross.
Okay, light off either.
Again, the right one dilates, left one remain constricted. See that? Asymmetry is very gross now. Now it is constricted because light is fallen on the table.
Can you off either?
I think the first part will be met.
Light it.
Now I am switching see the dilatation right and left. Right is slowly dilating very well, left is not dilating. Did you say that?
Light it. Okay, light off either.
Again, see the right has become dilated now, left is not dilated. Okay, so there is minimal dilatation in the pupil if at all it is present. That's a Horner syndrome. So is it Horner syndrome? Could be, because that's a clue to diagnose this thing. So is it not funny that you think a patient has got ptosis due to something else and pupil constriction due to Horner's? It seems quite illogical to think two different diagnoses for a single patients. So what are the tests will you do to confirm the Horner's? Ideally. Pharmacological test, no? But then pharmacological test is cocaine test, there is a apraclonidine test, methamphetamine test, but none of these eye drops are available in the market. Cocaine is not at all available and is very costly, but here is apraclonidine, as the other is methamphetamine. So you can get it in the market. So very difficult to confirm. Only the test book is there. You cannot do it at bedside. So you have to go clinically only. Now let us see what else could be the possibility in this patient. In addition to the Horner's pupil, anisocoria can be more pronounced in dark. It's not only seen in Horner syndrome. In physiological anisocoria also, it can be sometimes more pronounced in the darkness. Meiosis due to posterior iris synecdoche. Pharmacological meiosis due to parasympathetic agents like traumatic meiosis, iris ischemia, and chronic Adie's pupil. Okay, so these all can cause anisocoria. There is small pupil which is abnormal and which is more prominent in darkness. This all can produce that. Because the right pupil dilate, normally pupil dilates, left pupil will not dilate. So because of all these possibility it can be made. In physiological anisocoria, it should dilate, but sometimes asymmetry can be there. So it can be physiological anisocoria as a first hand. Very unlikely because in physiological anisocoria, pupil size difference is no larger than 1 to 2 millimeters, and typically same in dark light conditions, usually. However, in some cases, it can be more pronounced in the dark, but the pupillary right reflex is intact and equal between the two. That's the point differentiation between. It can be asymmetry in the darkness, but the reaction to the light should be equal in both normal and the abnormal people. Persons with physiological meiosis and the other people, the reaction should be equal. Even passivity can persist even during darkness. So, but here, that's not the situation. The reaction is very sluggish onto the left side. The main characteristic that distinguishes physiological anisocoria is an increase in the pupil size with lower light or reduced illumination. So why not physiological anisocoria in a patient? The difference in pupil diameter is more than 1 millimeter, and there's hardly any dilatation in the dim light, unlikely to be a physiological anisocoria. Okay. Physiological anisocoria, the sympathetic system is intact. So you should dilate. Here, hardly any dilation. That means it is not a physiological anisocoria. So that part is settled now. Now coming to the other tests which we can do to discover the causes. Meiosis due to posterior synecdoche, pharmacological meiosis due to some drug installation. Trauma to the iris which has happened earlier. And then lastly, chronic adistonic pupil. That will come later on. So what other tests will you do now? You find out these possibilities. Meiosis due to the endocyclitis or due to meiosis, etc.
That one will be irregular, sir, if there is synecdoche formation.
It should be correct.
Irregular.
Yeah, it is too small that you cannot really assess the regularity.
I think a dilator, we can put a dilator or metropin or something and see.
Okay, very good. So we did a tropic allele test. Tropic allele is a parasympathetic blocking agent. So this is before tropic allele. See the symmetry of the pupil now. Now, about 15 minutes after tropic allele sets. Look at the right and left is dilated and irregular. It's quite oval type irregular pupil. See the regularity. Much more dilated than on the right side. That is dilated round. It's also much more dilated than the normal side and the regular pupil. On convergence, convergence reacts. Light reaction is less. So, what is the diagnosis? So this is excluding, all these conditions are excluded. Because they should not dilate, because there is a parasympathetic overactivity, other is adherence, so it should not dilate at all. So what is the other possibility? Can be an Adie's pupil.
Yes, sir.
Adie's pupil is usually dilated pupil, large
Yes.
pupil. Adie's pupil should be large, no? Adie's pupil is due to the lesion and the ciliary ganglion are distal to that. It's due to the third now efferent fiber, the parasympathetic efferent action on the head, or only selectively confined to the ganglion and distal to that. See, atostonic pupil most frequently presents with a mydriatic pupil and light near dissociation. Vermiform iris sphincter muscle involvement. Some part will constrict, some may not constrict. And anisocoria greater in the light. Hallmark is the strong and tonic response near stimulation with the slow and sustained relaxation due to sphincter regeneration and hypersensitivity to muscular receptor agonists, that is pilocarpine. I'll explain it later on. The home side pupil is that pupil is dilated and reacts sluggishly to right and also to accommodation. The characteristic is the light reflex is less compared to the accommodation, just like our ARP. But once it is contracted, the characteristic finding is a slow relaxation for both accommodation as well as for the light effect represents. So light reflex is less compared to the accommodation. Once it is accommodated, pupil become constricted. You remove the light, it's slow, or remove the command, look at close quarters. The pupil slowly dilates, takes longer time to reach the original state. That's called the tonicity of the pupil. That is a characteristic feature of the tonic pupil or the home studies pupil. Now the twist is that in a chronic Adie's tonic pupil may be characterized by a myotic pupil, as opposed to a dilated pupil as defined in the home studies pupil. In tonic phase, you get a myotic pupil, like a dissociation, and anisophoria that is greater than darkness. This is called the little old Adie pupil. Over time, the tonic pupil, which is usually larger than uninvolved fellow eye, has become smaller, a condition that is known as the little old pupil. So this is again some information from the literature. In approximately 25% of the cases of Adie's tonic pupil, the pupil decreases in size by 2 to 3 millimeters over the course of several years. In this case, the abnormal pupil becomes myotic, referred colloquially as the little old Adie's pupil, and this is more pronounced in the dark and the light. The tonic pupil in all cases characterized by slow redilatation following the light stimulus, if the reflex is at all present and near reaction. A chronic myotic Adie's pupil maintains this characteristic slow redilatation. This compared to the dilatation of the normal pupil in dark setting, chronic myotic Adie's tonic will remain relatively more restricted. So coming back to our case, is it a chronic Adie's pupil or Horner syndrome? Forget about the ptosis regarding the pupil. Which will be preferred? Both are possible. Both can produce failure of reaction during light, during darkness. The anisophoria in both Horner pupil and many chronic Adie's pupil more pronounced in the dark. However, the crucial difference between the two disorders is the intact pupil effect plus in the Horner's pupil and light near dissociation in the Adie's tonic pupil. Here you find that light reflex is much less compared to that of the accommodation. And moreover, the irregular pupil suggests more of an old home studies pupil. That will not get you get in a Horner's syndrome. Because the sectoral pulse is typical of Adie's pupil. But intact light reaction, if it present, there was a Horner's. This is some point. If you think light reflex is present, there's a point for every Horner's. But here in our person, the light reaction is much sluggish compared to the accommodation reflex. So most likely it is it's a little old Adie. So you can clarify your points, doubts in this patient. Before I go into a short case history from linear order. Any confused?
Will an old photograph help in this case?
Pardon?
Old photograph.
Yeah, it should be an old photograph to find it. But photograph is not enough. You have to something we must have examined the pupil, then only we can get an idea. The photograph, you can't see the pupil.
So what is the final diagnosis, sir?
And one is it's got an orbicularis overaction because of the blepharospasm, not because it occurs on prolonged reading and doing some activity. And we can document their overactivity by the EMG. So whether it is functional or blepharospasm, most likely it looks like a blepharospasm itself, dystonia itself. The second one is pupil abnormalities. Most likely there are two possibilities. honest versus home studies pupil. To me, looks like a old honest or home studies pupil because of the poor light reaction and the irregularity of the pupil in this patient.
What about the history, sir? What is the cause of that eye ptosis while chewing or by talking?
That's a typical of any focal dystonia because they are precipitated reversal by certain trigger stimulation. It's classically, for example, in any dystonia, this is an important point. So look, I can show a lot of videos with me where the dystonia is precipitated with some tricks. Some people who are going on speaking, the eyelids will come down. Okay, or when the patient is what do you call it? Leave the blepharospasm also by touching the forehead. These are some quick movements which can happen in focal dystonias.
So,
Spasmodic dysphonia or a chewing dystonia can get alleviated by just putting some kuchi or something inside the mouth. Or putting some chewing gum inside the mouth and speaking, speech will be perfectly normal. The moment you take it out, speech becomes abnormal because of the dysphonia. So these are all well known in focal dystonia as a characteristic feature is called this antagonist. Antagonist is that some trick movement can alleviate the dystonia, some movement or can precipitate the dystonia.
so can we call this Marcus gun jaw winking, sir?
No, it's not Marcus conjoint winking. Marcus conjoint winking is a congenital aberrant reanimation where you opening the jaw, the patient's got already congenital ptosis. And when you open the jaw, the tooth becomes eyelid open. That is the Marcus gun phenomenon or jaw winging phenomenon. That is different. Here, what happened, prolonged speaking, and gradually, it's not an immediate contact. Gradually, the eyelid slowly becomes smaller and smaller.
So in this patient, the blepharospasm on left side, that is for, I think, less than 1 year, no, sir?
1 year.
Less than 1 year, and the right facial nerve palsy.
That's
and then Adie's people. So is there any underlying, there could be an underlying any predisposition, inflammatory lesion, and whether to consider this irritative lesion facial nerve?
Yeah.
Because all these are coming for the same patient.
Correct. You know, we have to think, I had not thought about that lines. This thought may be unrelated one, which is common gets improved. Other things are persisting. That is what it may be. The people patients never notice it. Only we notice it.
Whether there is any common link.
That's a possibility. You have to always think in if you get multiple findings in the same patient. The idea of bringing the case is to show this, to approach a person with ptosis. Many things should look for. One is the correct, whether the ptosis is corrected or not. In LPS palsy, ptosis is not corrected. In the ptosis correction occurs in two conditions. One is honest, the other is elevated dehiscence. Elevated dehiscence, looking up or down, the eyelid is always lower compared to the opposite side. Whereas in myopathic ptosis or that ptosis with Turner palsy or LPS paralysis, always when you look down, the level of the lid margin is same as on the normal side. And differential orbicularis spasm, orbicularis overactivity, look for the lower eyelid contraction. That's the best thing to look for it. But that cannot occur with any kind of ptosis. In honest syndrome, you can lower eyelid go up like that, but it's not the spasm. Remain up like this. That's called the reverse ptosis in honest syndrome. Another point is the pupil and the approach to anisocoria. There is how the smaller people require the different causes of it, how differentiate. That is my idea of my class today. Well, supposedly one may straightly jump into this honest. When you came to also it's honest syndrome, nothing. But you start examining, the eyelid is not getting corrected. That is why I went on looking up the weight test in this patient. Okay, any questions? Okay, case history from the gait neurology. This is because this video is very good. That's what I thought in this case. A symptomatic 61-year-old patient with no prior ocular surgery, but history of hypertension, hyperlipidemia, and hypothyroidism was noted to have.
Sir, a treatment.
Pardon? Okay. Now come back to the history once again. A symptomatic 60-year-old lady, a patient with no prior ocular surgery, but history of hypertension, hyperlipidemia, and hypothyroidism, noted to have a left myotic pupil during routine ophthalmic examination. Anosogorhea was noted to be greater in dark and was interpreted as left hornless pupil. Examination, there was no blepharotosis, no facial anhydrosis, eye movements were full, brain now examination was normal. In ambient light, right pupil measured 4.5, left was 3.5, just like our patient. In dark, right pupil measured 5.5, left remained for mild and there is the sense. Right pupil was round and responded briskly to light. Left pupil was irregular in shape, reacted poorly to light, but responded to near effort. Slit-lamp examination revealed poor temporal and inferior segment light sphincter movement. Following near stimulation, the left pupil slowly enlarged the baseline size. The findings consistent with long-standing or chronic Adie pupil. Let's see the video of this patient. This is pupillate reaction, minimal response to the left eye first. So similarly, the pupil right is reacting briskly, right is dilated, left is smaller, poor reaction. Now near reaction. On convergence, pupil reacts both on both sides, but remain constricted on the left side, slowly reacting, redilating. Again, making it constricted by convergence. Right quickly redilates, right, left slowly redilates. Infrared recording shows the asymmetry of the pupil size, regularity of the pupil size. That's called sacral palsy. So that's home side pupil. So home-sided pupil as opposed to an acute one, chronic one is narrowing, smaller, so smaller in diameter. But you can diagnose only when it is larger in the acute phase. Any questions?
Excellent cases, sir.
Yeah.
Excellent cases, sir. Sir, the previous case was a blepharospasm. Treatment, it was.
I put the patient Pacitane, but he did not improve much. And subsequently for further treatment and investigations and all, but he did not turn up. He said, I am not bothered much about it. I don't to go for treatment with bottoms and things like that. So I went up with one short case. This 61-year-old female came with this imbalance while walking with 2 years. Just see the video. He has got one eyes open. You can stand. Eyes closed, has got imbalance while standing. Positive rhombolism. He came with imbalance for 2 years. This is how he walked on tandem.
Functional, sir.
And this is called tightrope walking. So if you walk on a rope, tightrope, no, this is how you walk about it. It's got a perfect balance. That is why it's keeping it stable. No? He's showing this kind of height, upright, and stay. It's never fallen. It's falling only to the side of the wall. And other point before this, when you look at the page, when it turns around, turning around will be normal. If turning is okay, then he's walking again to the same side of the wall. Yes, that is correct. This is it. It's got a constant feeling of imbalance. That is his patient. Okay, shall we close now? Any questions? So that we can close.
So one doubt, sir.
Yeah, please.
Will you call if it is a functional or triple PD?
No, in fact, this is actually triple PD. Because he has a constant feeling of imbalance. That is why he's showing this kind of phenomenon.
Okay. Because not turning, no, sir. He didn't lose his balance.
Correct,
So I was
correct.
thinking whether it is, if it was triple PD on turning, he may actually,
Again,
it feels more of an imbalance.
no, the triple PD also turning will be perfectly normal. Because actually he has no loss of balance at all. He become more conscious when you walk about. When you turn around, he's forgetting about all these things. So see, we can turn around normally.
Okay.
And to become abnormal means he's okay.
How to differentiate from functional?
Triple PD is also kind of a functional gait disorder.
Yes, sir.
The same. Okay, shall we close? Okay, good night. Good night. Thank you.
Thank
all.
you, sir.
Thank
Thank you, Dad.
you. Thank you.
Good night, sir. Thank you.
Good night. Good night.